Good morning, everyone. All of you are here, and all those watching us online. We hope you have enjoyed the talk so far. I promised Corey I wouldn't take his time, so I'm going to speed through my presentation, hopefully. Okay, so for some of you who were at the opening ceremony last night, you probably have heard the first few slides, so I won't go too much into it, but I will be discussing on Cryos egg donors, how we select and screen our donors, and do a quick comparison between fresh and frozen donor eggs. And Corey will be speaking on whether we can find better eggs, a question we all have, and should it be based on morphology, spindles, zona pellucida, and also we will give you an overview of what Cryos has been involved in research. So let's start with our donor eggs. Who are our donors? They are healthy women between the ages of 18 to 32. Most of them are required to have some level of higher education and meet the physical criteria of BMI, antral follicular count, and AMH. AMH is very important, and we'll come to that later. Around 4% of candidates make it all the way through to egg donation. So fortunately, we are very, very lucky to have good donors coming to us, but the screening process that we do unfortunately ends up that we lose a lot of donors along the way. So out of 100 applications we get, we only have 4 of them making it all the way to OPU. Most like to donate for altruistic reason. And I was very intrigued to hear Ole and his honesty about donation, and we really appreciated your talk. Often they know some people that have fertility issues in their family or friends or surrounding. But of course, economical compensation is also something that motivates our donors to donate. I do like to mention, though, for the level of compensation they receive and the number of attempts they need to make to come to the clinic to be tested and then to have a scans, blood test, and go through the OPU, I'm sometimes wondering why they do it, but thank you to them. They get regular health checkup, and that's another thing that is quite important to our donors as well. We usually don't take donors that have AMH less than 2.5. We make sure that they are healthy through the physical examinations they get from our gynecologists. And we prefer sometimes, if possible, and it is getting more difficult to find 18 to 32-year-olds who have children in themselves. So it is a challenge, but we do like donors that have had children in the past. Additional criteria that we check, of course, is mental health. So beside the physical health is the mental health. We have independent counselors who see the donors completely independently from Cryos. They give us a report once they have checked that they know the implications of their donation, they have thought about their decision now, and they have thought about the decision 18 years down the line. We check their family history. We go back 2 to 3 generations and check to see if there is any issues within the family that could indicate to us that they may have some hereditary disease. We also evaluate their motivation as well, as we said. So, just very quickly, infectious disease, family history, risk factors. Are they smokers? How much do they drink? And all this can lead towards the risk factors that could put our donors and the future health of the gametes at risk. We do genetic screening, psychological assessment, as mentioned, karyotyping, blood type, and also AMH and antral follicular count. How do we get so much success from our donor eggs? Well, we vitrify only top quality metaphase 2 or mature eggs. We have huge experience with vitrification. We are the experts in the field. We have been doing this as a thank you to Mr. Burke, who started the program after freezing thousands and thousands of eggs and successfully thawing them. So the program is very strict, and we stick to that program. The warming criteria is very important, and we will go through the reference clinics that we have, and I think you all may have heard about reference clinics. They are the clinics that collaborate with us closely. When patients obtain eggs from us, or clinics obtain eggs from us, we make sure that we train your senior embryologists, either by physically coming to your lab or doing this online. We send training eggs. We make this effort to make sure that you know how to use our eggs. And as a result, we have a good success rate with the thawing as well. The types of donors we have, ID release donors or non-anonymous, non-ID release anonymous donors, basic profile, where I think most of you have probably seen our website for the sperm. You know exactly what kind of criteria comes up. It will be very similar when the website opens next week. It will be very similar for eggs as well. So basic profile, we will have some essential information, and extended profile, you get a lot more information about the donor. And of course, the reservation is also free. Donors with extended profile. Sometimes patients wonder why we have these two types of profile. Some parents prefer to know more about the donor and prefer to have something more to discuss with the future child. And we do give that option to them as well. And that's why it's very important that we provide this choice for the patients and for the clinics that choose for the patients. So we have in the extended profile childhood photos, question and answers, very extended, from the donor, family tree, personal letter from the donor, handwritten, emotional intelligence report, our staff take impression when they meet the donor, and we have an audio recording, and for some donors, we have adult photos as well. So, the question that we often get from our patients, sometimes the clinics advise that it is better to use fresh eggs than frozen eggs. Maybe years ago, that was the case, when we could not successfully freeze eggs. But this has changed now. Vitrification revolutionized the process we could freeze our eggs. And as a result, and as a hard work that has been invested into the program we are very successfully freezing and thawing eggs these days. A very quick advantage and disadvantage table I've prepared for you. Of course, with fresh egg donation, you probably get higher number of eggs, you probably get more embryos, and you have maybe more embryos to actually cryopreserve for the next cycle for the patient. I'm talking back to myself, wow. Okay, and maybe the consecutive cycle would be cheaper when you thaw the embryos. And the success rate, many people believe that it's a better success rate if you go for fresh egg donation. However, the time that patients need to wait to find the donor, to screen the donor, to synchronize the treatment of the donor with the treatment of the recipient, we know that in some countries, when there's so much lack of donors, some patients wait a year to 2 years. That is definitely the case for my colleagues who've come from UK, when you have to wait for the right phenotype so that the patient can be matched to them. The synchronization can be touch and go sometimes. It works, sometimes it doesn't. There's a cancellation risk if things don't go well with the treatment. And there's donor liability. Did the donor take the medication correctly? Now you have the recipient ready and you want to make sure that your donor is ready. Could there be a case of empty follicles? Maybe risk of hyperstimulation. And of course, the compliance with the country and the origin that the donor is and the recipient is to make sure that they match. And of course, initial cost is high. Why? Because the donor has to be paid compensation from the patient directly. However, looking at frozen eggs, we save time. We've got them, they're ready, they're sitting in our large tanks you saw yesterday, and they are ready to be shipped out to your clinics. It's convenient, there is no synchronization, no cancellation risk, no donor liability, there's a large selection of donors to choose from rather than having to wait. And the success rate is getting better and better, and we look at it. And of course, yes, the disadvantage is the patient gets 6 to 8 eggs. But most of our patients that come through for egg donation tend to be the women over the age of 40. How many embryos do they actually require to keep frozen? And if they have one, and maybe a sibling, 2 children, what do they do with all those frozen embryos that they have? They must face the dilemma of making a decision to discarding those embryos. And that's a very difficult decision for some patients. The cost, yes, might be more on the consecutive attempts, but we in Cryos, we actually guarantee our eggs, and we have a guarantee program, which I'm sure you heard about it last night. So just a very quick look at why we are still so concerned about frozen eggs, and why we believe that frozen eggs will not do as good. Back in 2010 when vitrification was still not widely used and was very successful for embryos, but not as successful for eggs, they couldn't prove, they couldn't demonstrate with this paper by Kobo et al. That using fresh eggs was actually better in terms of ongoing pregnancy. So they couldn't prove that. So they compared the two, fresh versus frozen. And Sol et al., they actually in 2013, again, couldn't demonstrate that the functionality of the oocyte or the capacity that could give rise to ongoing embryos and pregnancies and live birth was any different. Then in 2017, Crawford demonstrated that there was no evidence between the implantation, pregnancy, or live birth rates amongst transfers between fresh and frozen eggs. And this year, back in 2020, actually, not this year, there was a paper that really did a nice comparison and showed us that, maybe 6 and pushing it to 8 eggs would be more successful on the ongoing and live birth. So when we look back, we will see that actually there wasn't a need of this worry that we have been projecting to the patients about vitrified versus fresh eggs. If we look at the SART results of 2019, which is the last pooled report together, we will see that in this table, we've got quite comparable pregnancy rates. And if anything, single-tone pregnancy, which is what we are after these days, is higher with frozen eggs. And we have got more babies going to term because it's single-tone. And also the most talked about process, put one embryo back, get the pregnancy from that. We'll see that it's even higher with frozen eggs. I know I'm running out of time. I'll be very quick. So the quality of the eggs you freeze are very important. The ability to freeze and thaw them effectively is very important. And you need expertise of people who know how to do the program and expertise of the IVF clinic that will be thawing the eggs. Embryo development and the guarantee program will give confirmation to our IVF clinics that they are using the best quality eggs they can. The impact of us all the way to make your life simpler, to have one task at a time and make sure that you can rest assured that the quality of eggs you get is good. I won't go through all of that because we have now got Mr. Burke here to do the rest of the presentation.
Yes, let me follow Saghar. It's always fun to speak after her because as she said last night, she's a huge talker and doesn't know when to stop. So she just went through everything that we do to evaluate donors before they come in. But how do we find the best quality egg available? There's several ways that people have looked at, but I'm going to try and make it a little short because she took up some of my time. So basically, we have a few things that we've looked at. They don't seem to pay off very well. And sadly, the place where we are today, the best way to look for a quality egg is morphology. That's what we have. That's the tools that we have to really identify a good egg. So again, morphology is still the #1 way to select a good quality oocyte. In our labs, we discard about 15% of the M2 oocytes that we recover, just because they're morphologically not perfect. Being morphologically not perfect may mean that they have a genetic impact, something like that. If there's an embryologist in the audience, I know that you've probably inseminated eggs that are oval-shaped, and you've made perfectly good embryos. But we have an issue with selling those things. If you receive the frozen eggs like that, you'd say, what are they selling me? These eggs don't look right. So morphology is a thing that we have to go on, and that's the best thing that we have. It's, of course, subjective. What I see and what somebody else sees may be different things. But along these lines, one of the big things that's coming along these days is artificial intelligence and machine learning. We can take these things that look at the eggs, and they can predict if the eggs are going to be good. It's still a long way off. It requires millions and millions and millions of data points to build this and get the machine learning and artificial intelligence going. But someday, and maybe not the too near distant future, we should be able to have some machine intelligence that will be able to select a better egg. One thing that we have looked at is polar body biopsy. Okay, polar body biopsy is okay if you have a fertilized embryo and can look at both polar bodies. It doesn't seem to do a lot when you're just doing the first polar body. It can be okay, but there's still errors that go on with the next cycle of when the egg develops. Diagnostic accuracy is questionable. About 5 to 8% are false positives. And there's been some work that says that disrupting the zona pellucida is an issue. So when you freeze an egg, you have to fill it with cryopreservation fluid and equilibrium fluid. And poking a hole in the zona, it kind of breaks that seal, so it can be a problem. And also when you develop the embryo, if you have a hole in the embryo, I've seen it myself. You have a hole in the zona pellucida, you start to develop it, you get 4 cells or so, then you start to have cells fall out, and you have the embryo fall apart. So, and then Dr. Levin published a paper a while ago that said, the damage rates for polar body biopsies are significant. One of the things that we've been looking at recently is spindle size, spindle formation, spindle location. And this seems to have some good promise for us. Hopefully we can develop something in this regard. There's studies that say the spindle location, 0 to 29 degrees, is ideal. Certainly the size of the spindle makes a difference. There's been numerous studies that say spindle size of 80 to 100 80 to 100 micrometers produce a better pregnancy. Less, not as good. Greater, also not as good. So there's something to it. IVF Australia did a study with 100 patients undergoing ICSI, and they found that fertilization, blastocyst formation, and pregnancy rates were significantly increased when an oocyte was a normal size and normal shaped spindle. So there may be something to this, and that's something that we have just, technology's been around a while, but we just haven't gotten to that point of using them, because a lot of the spindle technology started before we were able to vitrify eggs, so they kind of stopped for a while. And now that we can vitrify eggs and look at them differently, it's going on again and has some promise for us. And to go along with that is zona pellucida perfringens. This seems to have some significance as well. Low versus high makes a difference. High perfringens is of the inner zona pellucida layer appears to be an indication that the optimal structure formation during oocyte maturation, leading to better embryo development and competence in implantation. Studies have shown that pregnancy rates are improved, and more studies are definitely needed, but we're hoping to go that way, and maybe in combination with a spindle formation, may be able to pick a better egg. Just to finish up a little bit, I just want to tell you a little bit about the research that we're doing. We talked about last night and earlier this morning. One of the big things that we've done is, with the pandemic, one of the big questions has been in sperm. Is sperm affected by it? Not so much affected by it, but is the virus in the sperm itself? We recently did a study, and that's the top study there. It was just published earlier this year. We found that it's not. Most of the papers that have been out find the same thing. We've also published recently a paper on attitudes of sperm donors in Denmark and the United States towards offspring identity release and extended genetic testings. And we're working on projects, both long-term effects of COVID and the vaccines on egg donors and sperm donors. There's been a lot of discussion about that. We don't really know because we haven't had a long-term. Long-term is relative. It's 2 years into the pandemic. Do we have any long-term studies? But we're looking that way. So we're looking at AMH levels in egg donors, and we're looking at the effects on sperm donors. And there's also been a big question lately about the vaccine. Does that affect anything? So we're looking at all these things, and hopefully we'll have some answers for you shortly. Of course, long-term is long-term, but hopefully we'll have them. And thank you to Cryos. Everything's personal, so thank you very much.